So now moving on to some issues that are on everyone's minds, and I'll refresh everyone's memories that speaking about what other aspects of public health is involved in, we do have a community health indicator report, which is data driven. We take all of the data in the community, and then we work with a healthy community collaborative, which is made up of 60 different organizations and individuals in the community to identify what are we going to work on collectively in a community health improvement plan. And on that plan, it's substance use, it's mental health, and substance misuse, healthy eating, and active living. And that's what we're going to be talking about today. And so I would like to have our medical director come up, Dr. Urbina, and he is going to give us some basics, and bear with us if you already know some of the stuff, but I think it is really important to start with the basics and then take it into some more detail. So with that, Dr. Urbina, if you could go ahead and start your presentation.
I couldn't resist. You know, that's my favorite opening line, to turn on the microphone and then not speak to it. So I also want to invite Heather Graves up. Oh, she's here. Good. We're going to do this presentation together. I just wanted to give a little background, and I'm glad to be here. I'm glad Susan's back as well. I'm excited that she's here. I was actively involved when I was at CDPHE in the early development of the Colorado Consortium for Prescription Drug Abuse Prevention, when the Governor Hickenlooper at the time and our Attorney General, and now our Mayor, Suthers, was actively involved in this. So this is not a new problem. We've been having opioids and the challenges related to opioids for decades, and it seems to come in waves. You can go back in the history of prescription drug use or abuse, and you can see the trends that are happening. And now we have this very deadly chemical called fentanyl. Now, so I'm going to walk you through some of that history, walk you through some of the data, and hopefully engage in a conversation, because I do think public health has a role in developing and participating in the actions going forward. Not the only role, but a very important role. So next slide, please, Haley. So just for reference, I'm a family physician, and I prescribed lots of narcotics in my day, and we didn't really realize at the time that prescription drug abuse was an issue. And so we prescribed these almost like candy. I'm embarrassed to say that we didn't have very good control over how we were prescribing these narcotics. And still to this day, although I'll talk about this, there are lots of opioids out there, and they're appropriate use of opioids, and I'll talk about that in a second. But there are lots of opioids, and you all know, and you probably have taken them in your lives. They're natural and semi-synthetic, but the ones that we're concerned about now is the synthetic ones, and the derivatives of fentanyl. But they've been around for a long period of time, and I'll talk about this. And there are also drugs that were buprenorphine and tramadol that are safer, but still important to check. And they all work the same way. They act on our mu receptors to control pain. That really is the essential ingredient in how we use opioids as a physician, or a veterinarian, or a dentist. When's the last time you had dental care? And they usually prescribe narcotics because dental pain is very painful. Veterinarians prescribe it as well. But the challenge for us is that there's a reward center in our brain, and I'm not an addiction specialist by any means, that gets turned on. The narcotics also not only inhibit pain, but they also create a euphoria and a reward system that's very addictive and dependent. It creates that dependence. And most of the time you can say after 5 to 7 days, you can safely before 5 to 7 days, you can safely take narcotics. But after that, as Dr. Vu will testify, after that is when the addiction starts, or the dependence on starts. Next slide. Let's talk a little bit about fentanyl. Because for the longest time, and Dr. Vu and I probably prescribed this, particularly around hospice patients, people in intractable pain that really needed severe connections. And so we titrated it. It was useful. It still is useful. But then as many of the companies around the world, and Dr. Turbush alluded to this earlier, is that many of these international companies developed this semi-synthetic fentanyl. Very potent, 50 to 100 times more potent than morphine. And when you think about morphine or heroin, that's incredible. That's incredible that it's 50 to 100 times more potent. And what we're seeing now, and I can go into discussion if you'd like to hear more about it, I'm sure many of you have experienced this. Now, opioids on the street are now being laced with essentially fentanyl. So a consumer who's dependent or has a substance use disorder may pick up a pill. And several high-profile cases have happened in El Paso County because of that, because they were unaware that fentanyl had been laced in their Percocet pill. It's added to cocaine. There were very high-profile cases in East Denver or in Aurora where people were using cocaine. It was laced with fentanyl, and they died. So its impact is greatest in people who are unaware that it's being in their chemical. It's being mixed in. Yes, Commissioner or Council Member.
Yeah, Dr. Urbina. What's the purpose of lacing it with fentanyl, like cocaine? Why did they mix that in there? I've heard an explanation, but it's just kind of.
I've talked to my colleagues about this, and this is the issue. It's cheap. It predicts a greater amount of dependence and addiction, so you're creating new users by lacing it, and it creates a little bit higher high. So it's a very inexpensive high that people can use, and basically the sellers of this drug are using it to market and create new dependence on this market. It's kind of like a fast sale, cheap, and a way of generating more users of the drug. That's the easiest explanation I can give you.
And so, but for, say, people who use that drug, the cocaine or whatever, if the word is naive, their body hasn't been exposed to it, it can OD them, wham, they're dead. Whereas someone who's been addicted for a while might be able to not have that reaction. Is that part of it? Or
surprisingly, even people who are chronic users or people that are dependent on opioid can still overdose on fentanyl. Sure, it has to do with the concentration and the amount that's in their chemical. Yeah. And now, as you know, many people are testing drugs on the street with fentanyl strips so you can actually identify. The challenge is when you look at it in a pill form, that small little grain or sand of fentanyl could be on the other side of the pill. And no one is going to really smash up their narcotics to actually test the entire thing. So that's the challenge, is that a naive person more likely to die, but even a chronic user can also die depending on the dose of the fentanyl they consume.
Sure, thanks.
Yes, Commissioner.
And to be clear, the fentanyl-laced Percocet, as you mentioned, is not the Percocet that you would legally and properly get when prescribed from a pharmacy.
That's exactly correct.
Version.
These are all street drugs, and that's why I mentioned that in my comments, is that it's processed. So it's you're bringing together a traditional, a narcotic like Percocet or oxycodone or any of the things I listed up, and you mix it with this fentanyl, gives you a little stronger high, and that's the challenge for us as people are trying to prevent this from happening. Good point. Any other questions? I'm glad you're asking these questions. I think this is the issue. All of these narcotics cause respiratory depression. All of narcotics cause respiratory depression. And those naive folks, or depending on the dose, it can cause death as well. Very difficult to reverse. You often see people, and it's dose dependent, of course, take 2 or 3 doses of Narcan. And there are no first responders here, but many of our first responders will say, boy, they didn't recover. They didn't recoup. They'll give 2 or 3 times the amount of Narcan. And that's a drug that replaces or displaces the receptor or the opioid from those mu receptors that I talk about. So, next slide. This is an important slide because I wanted to give you some background, is that this has been going around, I alluded to this earlier, it's been going around for a long period of time. Early on in the crisis, 10 to 15 years ago, we had talked about getting rid of the prescription pad, or basically restricting our providers from prescribing inordinate amounts of narcotics. And I was one of those. I admit that I was naive about my impact of my prescriptions. But now we've got great training and really have reduced the amount of people who are actually prescribing drugs, and we've gotten alternatives to that. So this has really been an important trend, because if you look on this continuum, there's misuse, that's a substance use disorder. There's substance abuse, and people naively will take one Percocet pill they didn't know it was laced with fentanyl and die because of that abuse, not aware of it. There's occasional users, obviously somebody who has a dental issue may take 3 or 4 Percocet, for a day and be completely fine, not going to be dependent on it. And finally, people that are adherents that actually have chronic use. So Dr. Vu shaking his head. Well, we've all prescribed our narcotics for people that are appropriate amounts of narcotics. When I had my knees replaced, my orthopedic surgeon gave me, 100 Percocet. What? I said, I don't need all these. He said, no, you're going to use them. So I took 18 of them. And it was useful, important, appropriate, adherent use of narcotics. It's when the abuse or the dependency comes in. So next slide.
Dr. Urbina.
Yes.
If I could, I always remember this from when I was in PA school back in, say, 98, 99, is back then that's when pain became this real big thing we had to get ahead of. You had to get ahead of pain. And so we were told
Absolutely
that you needed to prescribe narcotics to get ahead of the pain. You were really encouraged to do that as a young PA, young doctor going into medicine at that time. A few years later, I don't remember if it was 5 or 10, all of a sudden the brakes went on. Oh, bad idea, because the opioid addiction crisis had hit. So it was just interesting. I happened to go through PA school at that time when we were really pushed to prescribe this stuff. I never felt comfortable doing it because, as you point out, there's an appropriate level, and then there's this give them 100, so they don't call in for a refill.
Sure, and as I said, actually, a good point, City Council member, is that we gave them out. We created some of the dependence and addiction, but we didn't do it all, because obviously there are a lot of people that like to use narcotics and like to use street drugs that we didn't cause as health providers. So, but I can take a little blame, but not all the blame. So.
There was a real change in philosophy at that time because
Absolutely.
Pain became the 5th vital sign, if I remember right? And Dr. Vu's shaking his head. He remembers this too.
Yeah, so there was a point where hospitals and clinicians were graded for how well their patients' pain was controlled.
Yeah, it was called the vital sign. We had how do you eliminate pain from 1 to 10? Yes, that was the issue, yes. But now, hopefully, that's in the past. I show this pyramid because it's important to point out that for every death, it impacts other people. 18 people are, this is from 2018 or 2017. 18 people had a substance use disorder involving opioids. 62 people had a substance use disorder involving prescription opioids. 377 people who misused prescriptions opioids in the past year, and almost 3,000 people who used prescription drugs. It's really the tip of the iceberg. So when we talk deaths, the problem is much bigger than the death associated with fentanyl. So I wanted to point that out because this is a important, serious discussion. Next slide. Well, I'm going to be channeling Fadi here. In terms of the data, I wanted to give you some perspective on the impact of drug-related overdoses in Colorado in general. And I do have some slides from Dr. Kelly that I'll share with you in terms of local data, but I wanted to give you the bigger picture. And I took the same time period, 2016 to 2020, and if you look at overdose deaths, that's the amount, 5,400 overdose deaths in the state of Colorado. And if you look at El Paso, over that same period of time, there were 751 overdose deaths. 751 overdose. Keep that in mind as we talk about the deaths related to fentanyl. And fentanyl is an important one, but overdose deaths is also important in the state of Colorado and in El Paso County. Next slide. So I wanted to focus a little bit on fentanyl. Again, this is what this talk is about. If you look in 2020, and I look in El Paso County, we had 92 deaths. And I'm going to share with you more data over the last 4 years for El Paso County. But compared to the rest of the state, you can see the small surrounding counties, the impact, like Pueblo, for example, has 21 deaths in 2020. But the significant amount of deaths is still in the Denver metro area. Next slide. I also wanted to share with you the impact of overdose related to hospitals. And we talked about this. So if you survive fentanyl or you survive your overdose, it still impacts our healthcare system tremendously in terms of the recovery. And so I want to just point out that in the same time period, we had nearly 3,000 overdose hospital admissions at acute care hospitals in El Paso County. Next slide.
Dr. Urbina.
Yes.
Sorry, I don't want to slow you down too much, but in comparing the age group ranges in the what's also apparent to me is that in that 65 and older age group, these are most likely either accidental or not. But I mean, I see a big jump in the fact that it's probably not recreational use.
Correct.
So at some point, I would love to hear about specific
Age groups.
efforts in that aging
Sure.
population
Sure.
On this, because it doesn't correspond to the deaths.
I'm going to share, Commissioner, with you some data in El Paso County. So you're right, because I think it's important. The targeted solutions, Heather will talk a little bit about this, are different for an adolescent than they are from an elderly standpoint.
Right.
So if I have a 75-year-old person who has chronic knee pain or chronic back pain, I'm not going to prescribe a narcotic.
Right.
They may have available narcotics, but we'll try acetaminophen, we'll try physical therapy, but that wasn't always true, as City Councilmember Donaldson will remind us, is that we gave narcotics to the elderly, and I think that's the issue. We are also giving benzodiazepines to the elderly as well, and that combination of benzodiazepines and narcotics, very deadly. So again, you're right, interventions are completely different. So I'll talk about those age ranges when we go back to El Paso County.
Thank you.
But thank you for bringing that up. Just wanted to share, and I'm channeling Fadi again, because I think this is what you bring up, Commissioner, is a comparison to comparison. When you factor out age and you do an age adjustment rate, not just raw numbers or crude rates, it actually doesn't look as bad, but it's still important to compare population to population. So when you look at age-adjusted rates per 100,000 in El Paso County, it's 2.5. Compare that to Pueblo, 2.9. Or compare it to Denver, it's 6.4. But I think when we compare apples, we have to compare them to other apples and not apples to oranges. So I just want you to know that following these trends and rates and counts is important, but following rates is more important. So I shared this with you. So the next slide.
One fast
Yes.
question on that one. What's going on down there in Los Animas County?
Yeah.
They're like off the scale.
It is tragic. So you're talking about a different population, and I can't speak for Los Animas. I'm not a commissioner there, nor am I a member there. But there's a significant challenge with street drugs in Los Animas County and Huérfano County. It's also, but again, you point out that, right, we've adjusted for population size, we've adjusted for age, and that's a big issue. So, next slide. So let's talk about El Paso County data. And I received this from Dr. Kelly. So you can see the significant trend from 2016. Accidental fentanyl deaths were 4. And now it's 102 in 2021. Do you think we have a problem?
Yes.
Yeah, I would say so. So this is real. This is real data. And so we could talk about overdose deaths in 2016, and people were using street drugs. But now the fentanyl has become very deadly. And so next slide. So let's talk about that age ranges that Commissioner alluded to earlier. If you look at those 102 deaths, and then we again thank you for Dr. Kelly for giving us this, 71 were males, 29 were females, and 2 transgender. Age range was from somebody accidentally from a very young age, 1 to 67. The mean age was 38, younger population. And you can see if you look at the age ranges, and the pie chart will share that with you. Under 18, there were 5. 18 to 29, there were that's 28. 30 to 39 was 37. So again, it's a working class group of folks. It's not necessarily the young or the old. If you look at 60 plus, that's still a small number, Commissioner. That's 6. That's the orange of that pie chart. So we can actually go back and look at these for each of the years. Dr. Kelly will share that at a future meeting if you'd like. Next slide, and final slide for me. Solutions. And I hope we can engage in some discussion here, and I know you have ideas, but obviously a comprehensive strategy involving broad community support, mental health partners, schools, police and public safety partners, the criminal justice system, our health providers, including dentists, veterinarians, policymakers, public health, churches, and other community partners. It really has to involve all of us. Public health doesn't have just the sole responsibility for this, nor do our health providers. It really is all of us are responsible for this. Some education and awareness of the dangers of fentanyl. I talked to some of my colleagues, and they say 1 out of 4 street drugs is laced with fentanyl. And I thought, no, how is this possible? But this is the reality of people testing the drugs on the street with these fentanyl strips. 1 out of 4. Drug policies with early treatment and follow-up. Narcan, obviously, that we've solved that problem of having it readily available. The availability of medically assisted treatment. I won't go into this. I'm not a MAT provider, but of getting people into treatment is essential to solutions, of getting people to recognize they have an issue, a disorder, and getting people on some of the chemicals that we talked about. And finally, because we don't want narcotics floating around out there, we want to get people safe disposal. I'm going to stop there and turn it over to Heather, and then we can have a general discussion or ask more questions, if that's okay with you.
Hi, everyone. Hi, Heather. Can you hear me okay? Okay. Thanks for the opportunity to speak on this. I'm fairly new with the agency, just been in about 6 months, but I wanted to talk a little bit about the existing efforts that public health is engaged in for several years. So, okay. We are in the process of recruiting and accepting applications for a behavioral health planner. And this is really out of necessity to have a focused effort in behavioral health and substance use disorder. So I'll put a little plug. If you know anyone, send them our way and have them apply. But we're in the process of accepting applications now. We've been at the table of these conversations with other coalitions, collaborations in the community in this behavioral health planner role. But at this time, we're putting efforts and resources for a dedicated position in this area. So the position will work with community partners to assess and evaluate our community's behavioral health resources, services, and gaps. And then they'll look to close those gaps and make improvements. The other thing, one of the coalitions that we run, which I believe convene, which I believe Commissioner Gonzalez is a part of, is our Fountain Valley Communities That Care, and also recently received a drug-free communities grant in that area. This is a prevention model that seeks to promote healthy youth development and prevent youth substance use by increasing protective factors and reducing risk. And this has been convened through public health since 2017. Communities That Care and drug-free communities, it's the protective factors are increasing family support, community support, social connection, resources. It has an award-winning youth action committee that actually has youth and peers that are working on these initiatives for the community. There is a drug take-back day coming up on April 30th with this group, so I just want to mention that. And the learnings that we have in this group, we will share, or we do share, in our other collaborations and committees. And then the last thing I'd just like to mention is that we have our child fatality review team. Many of you probably that you've been involved, you're aware of this, but this was began with the coroner's office and El Paso County Public Health in 2014. And this is a group that is a multi-sector group with law enforcement, healthcare providers, DHS, public health, schools that review child fatality in El Paso County. It's usually almost a year behind, if that's the right word, but it's cases that are from the previous year. Then we come together, review those cases, and look for areas of prevention. And then we work to infuse education, communication, awareness, so that we can make an impact in preventing future deaths in those areas. Lastly, I would just add that, as I said, we're a part of many collaborations and committees throughout El Paso County. There's a large behavioral health steering committee that has again many multi-sector partners, and this is at the top of the conversation: substance use disorder, substance abuse, and mental health here in El Paso County.
Thank you, Heather. And Dr. Urbina, I wanted to add, maybe to refresh some memories also over the years. Dr. Kelly couldn't be here today because he's out of town. But back in 2014, we were extremely concerned about teen suicides. And Dr. Kelly and I convened many different leaders in our community, including schools, because these types of issues on substance use and suicide, some of the same prevention models help to gain some improvements on those issues. So we convened numerous different groups, and that's what public health does, is convene and then create action plans and use data to produce some results. And at that time in 2014, we left it open and asked the leaders, and this was the police chief. I know Tom Strand, you were involved in this, commissioners, National Alliance on Mental Illness, the hospitals. I mean, we had really large groups, and we asked these groups, what are the top 2 issues in El Paso County that you want to give some resources to and really dedicate efforts? And the top 2 issues that came out of that were issues facing youth, and teen suicide prevention was a top issue, and then youth substance use. And so what we did as a child fatality review team, and Tom Strand was also on the child fatality review team as well with us. And this is, really difficult topics. But we worked together to look for funding sources, because, funding is not plentiful in all aspects of public health, but we were able to secure grants where we hired a teen suicide prevention planner, and also with the help of the county commissioners to sustain those efforts. Now, if you I know you all keep track of our progress and community collaborations of how we've impacted teen suicides in El Paso County, and we need to keep up with that momentum. Now, the behavioral health planner is the same type of model where we are going to address youth substance use. And so these efforts are making a lot of progress, and it's only successful with a tremendous amount of support and efforts from the community and also leaders to make progress. And I will also say that the Fountain Valley communities that care, we were asking numerous different leaders, who could really pull it together, from the police chief to the city council to the school superintendents and representatives. It's not that the city of Fountain has higher drug rates among youth. It's because that community was ready to step forward, provide the leadership. And when you're talking about youth substance use, it's not, you make more progress when it's in communities or zip codes, and they really look at the policies and into the ground level, the protective risk factors that was what's going to make a sustainable change and impacts with the investments. And that's why that community was chosen. But there are various different models that could work, but it has to be much more than public health invested in the time and the resources that is needed. So we are making progress, but there is still a lot more to do, especially when you're talking about prevention. It's not a quick fix. It's not a quick fix in 6 months or a year. It has to be an investment, and it has to be long term, and that's where we will produce some results. But I did want to provide a little bit of that background because 2014, it's taking. It takes a lot of time to work on this. So I thank you. Heather and Dr. Urbina, and like to open it up for any questions on this topic.
Thank you, Chris. Thank you, Heather. I have one small comment, maybe two questions, please, and the questions about Narcan. So the comments really is perhaps pharmacists can be included in the category of community supports. Two questions about Narcan. One is, I don't know for sure, but in Colorado, is Narcan over the counter or does it require prescription?
It is over the counter, Dr. Vu. You can get it from a pharmacy. There are some public health departments in the state of Colorado actually train people and give Narcan to them. So that's available, yes.
Can I get your thoughts on the risks of and benefits of Narcan being over the counter? In my mind, the benefit of Narcan being over the counter is that it is widely available and potentially can save a lot of lives. The risks, some of the risks on my mind, number one is that we miss out on the opportunity of a face-to-face education between the person carrying the Narcan, the patient, and a clinician. The other possible risk of Narcan over the counter is people may not understand that Narcan is short acting, is much shorter acting compared to the effect of opiates. That repeated dose of Narcan may need to be used, and use of Narcan, even though it reverses the effect of opioid, there's a risk that the user may not call 911. So can I have your thoughts on those risks and benefits, please?
Sure. Thank you, Dr. Vu. Great questions and observations. Obviously, you've been out in the field. You understand how this works. When we trained first responders, policemen, fire, EMS responders, we trained those folks to also continue to monitor their patients. So it's not one and done. It's one and call 911 if you're if you're not available. Or if you're a first responder. So immediately you're continuing to monitor eye, sweating. Because remember, Narcan triggers a withdrawal. It basically replaces the opioid from the mu receptor. So you have to monitor these folks very closely. So you're exactly right. So we're not just giving Narcan on the street to just the innocent bystander. We're trying to train people as we go through. So it's essential. Two, I agree with you. I think Narcan has to be attached to a medically assisted treatment. If just continuing to not identify folks who are using substances on a regular basis, substance use disorder, or as Heather alluded to, linking them to care is essential. And so I think some of the partnerships, Heather can speak to this probably, is making sure that we have the available medically assisted treatment. At the same time, we're getting people into that. So many fire folks, policemen are now linking those to I forgot what the acronym stands for, LEAD, law enforcement diversions for getting people immediately after they given Narcan to get them into not into jail, but to get them into treatment as a way of getting folks to get off their substance uses. So you're exactly right. We have to link those together. It by itself. And I know there was a big push up in the Denver area. Many of the media was saying, well, let's just give it out to everybody. But I don't think that that's going to be sufficient enough. It may reverse it short term, but not long term. Correct. Thank you for your comments.
Thank you.
Steve?
Yeah, if I can make a comment on Narcan. Kudos to El Paso County. Early on, when Narcan was first being discussed as being for use by law enforcement, El Paso County was an early adopter of that. Our physician advisor in the county for EMS was right on the front edge of that and wanted to get it into the hands of law enforcement as soon as possible, because often law enforcement are the first ones on the scene of these kinds of overdose situations. I don't know how many have seen it, but in the news just recently, the last day or so, there's body cam video. I think it occurred a few months ago, but they just recently released it from Canyon City, where law enforcement gave 3 doses of Narcan to someone who was suspected of having a fentanyl overdose. That happens every day in our community. The use of Narcan by law enforcement has really gone up, and that's not to say that it's not being used by police and by fire and EMS also. Fire and EMS have carried it for decades, but more recently with law enforcement, and it's being used quite often. And again, El Paso County was on the front edge of that.
And we thank our first responders, and including our police, to help us with that. But again, as Dr. Vu pointed out, there has to be that link. There has to be a link to services, a link to an ER, a link to detox, essentially, for folks in long-term treatment. You're right.
Yeah, and there is a lot of work being done on the front end of diversion to decriminalize it, in the sense that these aren't people that need to end up in the criminal justice system, but they need to end up in the treatment system so that they can get clean of that addiction.
I agree with you. Could you roll back the slides, Haley? To the previous slide. You're right. That criminal justice system is key to this. We don't want folks that are suffering from substance use disorder to be detoxing in the jails. We want them in the facility so they can get treatment.
A question for you, Dr. Urbina. You know, I was curious how much it would cost for Narcan, and so I just tried to look on the phone here, and it looks like in Denver, they will actually mail it to people. They'll mail it to you. You just send in a request somehow along with fentanyl strips. But I didn't find a price here in the Springs area. And is the one that's over the counter, anybody can get it, is that nasal or is that an injection? Do you know?
Nasal. Nasal is the easiest to use. It's probably more expensive, but it's the easiest to use.
And how much do you know what the cost is?
I don't, but we can find out for you.
You know, Dr. Vu, what that is? Okay. Okay, thanks.
Thank you. I appreciate the update. I mean, we've seen the numbers the last 2 years. We've mentioned it from the county when we've gotten these updates of, the doubling from 1 year to the next, and then doubling again on fentanyl-related deaths, overdoses. And so this is something that we've been concerned about, and highly so the last couple of years. And the things that were mentioned here, we absolutely need to get anybody who's addicted and get them the help that they need. But as we've seen, we also need to address the issue that was brought up earlier on, for those that are pushing this, we need to make sure that they're held accountable. And so I do ask that the legislature, which has sort of on the side discussed this, they need to step up. They need to get rid of where they decriminalized some of the possession of this for drug dealers. They need to reverse that. They need to come out and stand boldly behind our community, our families, and the people who are suffering because of this, and reverse that legislative decriminalization of the possession for those that are actually pushing this out, and reverse that now, soon. I mean, they need to do it tomorrow. Thank you.
Other comments? Oh, great presentation. In public health, this health department can do more than one thing at a time. And I remember when we focused laser-like on teen suicide and made a big difference. We were in the newspapers nationally for the wrong reason. And then really changed that around. Our focus, of course, for the last 2 years goes without saying. This, I think, is a priority, and I believe that I'm speaking for others here on the Board of Health, and sort of giving Susan and company direction I believe, and I know you're already on it, but this is a huge deal and huge for not only our El Paso County, but for the state of Colorado. I would mention that public health looks for upstream causes and solutions. And just to mention again that I think one of the upstream causes are the precursor chemicals that are coming into this country, but also Mexico. Of course, that's a higher pay grade, needs to be addressed at a national level, but I think that's one of the things that maybe could come up again, maybe not in this venue, but how to address those precursor chemicals that are getting into to Mexico. This is such a good topic. Do we have any members of the public here that wish to make a comment or ask a question about the fentanyl deaths in our community, or elected leaders? Or yes, please. I'm sorry.
Dr. Turbush, I had one more question. One of the bullets at the end of Dr. Urbina's presentation said safe disposal was something that needed to be discussed, and then Heather had mentioned Take Back Day, April 30th, I believe, in Fountain. But are there any ongoing efforts to provide, other than, there's Great American Take Back Day, there are all kinds of efforts that seem to center on us being at a certain place and time with certain drugs to dispose of. Are there any ongoing efforts to ensure that there's always a safe place to take that back? I know personally, I had a similar experience, way more than I needed prescribed after a procedure. And, the pharmacies can't take them back because they can't, there aren't the proper controls over disposing of them there or accountability. So what are the options for the everyday person who needs to dispose of properly those drugs?
It's not. Thank you. Okay. You all, sorry about that. So the other thing is there's locked boxes, and there's education on how families can keep prescription drugs away or out of the hands of those that should not have that. So that's part of it. But in terms of general take back, I'll have to get back to you. Mm-hmm.
Anything else? Yes. Oh, please, go ahead.
Thank you. And just to be specific, I used a shorthand term, and I apologize for saying decriminalization. I don't want anybody in the public to consider this board or myself ignorant of the fact. What I meant was that removing fentanyl from being a felony to a misdemeanor for possession with intent to sell, potentially because of the amount that they had in their possession. So I wanted to just be very specific. I did use a shorthand term. Did not mean that out of ignorance. Understand the difference. Asking that people stand up and for the fentanyl to remake it a felony for the limited numbers, because even in the small doses, it's killing thousands and way too many people. Thank you.
Dr. Turbush, can I also add something to Heather's comments?
Please.
There are pharmacies that prior to COVID we actually had worked with around town in the northern part of Colorado to actually get them to take back some of the narcotics. It's very hard to do that. And that doesn't mean we couldn't do it in the future, but it's difficult to do. But in the interim, what I would suggest just over the counter, other than keeping them safely away from children, is you can smash them up, mix them up with coffee grounds, and throw them in the trash. That you can do with all your drugs, but do not throw them in the water or flush them down the toilet. because then we'll have a lot of pain addicted fish out there. We don't want to do that. So don't throw them in the water, but you can dispose them into the trash if you smash them up and put them in coffee grounds, kind of thing.
There you go.
Thank you, Dr. Urbina. I will add, there is a site on the Colorado Department of Public Health and Environment, which is a Colorado Household Medication Take-Back Program. There's an interactive map that you can go to for folks that are wanting to know where they can dispose of the properly in El Paso County. So that is, we'll probably put a link maybe on our website for easier access as well and get it out there.